Madam, I have made you the host.
Thank you. Good evening. I can see Dr. Ranjan. It's been ages since we saw you, doctor.
Yeah, that's
How are
right.
you?
I'm all right. How are you?
All good, doctor. Welcome
Ah,
back to India.
thank
You've
you.
been away from India for a while.
Yes, nearly 3 to 4 months I've been traveling India, Brunei, Singapore. So
Say,
Good
nice
afternoon,
to be
sir.
back. The time difference makes it a little bit difficult.
you mean India
To
and
attend.
abroad?
Yeah.
Mm,
The other speaker is Mohamed Hasan, no?
yes, Dr. Hasan Faraj. He is our gastroenterologist in
What's
Bahrain.
his family name?
Faraj. Maybe you know.
Maybe I've met
F-I.
when I went and visited Suleiman.
Salmania, maybe, yes. You
Salman,
might
yeah.
have.
Mohamed Hasan, Neelam Mohan. Good. It's going to be an interesting session, I think, today.
Yes.
Sir, good afternoon, sir. Good evening, sir. Saji here
Good
from IAP.
evening. Hi, how are you?
I'm good, sir.
Nice to hear from you. You have been organizing the meetings?
Yeah. Today's working, so
Good.
I'm just going back home. So I'm traveling, so no issues. I've just made Vanitham as the host.
Huh.
I'm there as a silent support. Any issues, I'll be there.
Thanks very much. Thank you.
Yeah, ma'am. Yes.
Thank you.
Okay, ma'am.
Dr. Neelam has been intimated about it, is it? Because I've not been in one-to-one touch with her.
Oh, really? How did that happen?
Yeah, because I think she's busy.
I
She's
think
unable
she's
to.
difficult to get on the phone. Yeah.
Yes, yeah, Dr. Neelam, I see her here.
Yeah, I spoke to her. She's just joining.
Yes, she did. Good evening, doctor.
Nobody spoke to me, but I joined.
Yeah,
Good
ma'am, you're there.
evening. Good
We
evening,
just thought
Dr.
of you and
Neelam.
you are here.
Yeah. I'm just realizing it's so dark here. Is there any light you can give? Unless this camera is so dull. I mean, do you all feel the same? I feel that I can hardly see anything.
Actually, you are glowing there, Neelam.
Oh, am I? Then that's lovely.
Yes, not joking.
Okay.
Yes,
because for me
meaning
it looks
we can
very
see
dark.
you, but I think the ever shining doctor needs to be shining more. So you
More,
need to
is
get
it?
Is there any light I can
illumination
have? The
background.
room light? The hotel people can get? Anyway.
Actually, if you move slightly to your left, there's more light. But
There
is
is
it
a
possible?
focal light somewhere there. Yes.
Because if you can ask
So
those
I think
people
it's
to
on
give
the
us
wall.
meters to घर पे भी है. Ask them for some ring lights or anything. Is this better here? You want to see that? He's right. Here it is better.
There you are.
See, वो better दे दो.
I think you come here. ये वाले से ऊपर तो यहाँ बराबर है.
Is this better?
आपके face पे बहुत light है.
Yeah, now it's good, actually.
Yeah. Great.
It's good.
Can I just try sharing or do we do it later or just a trial?
Yeah, you can do a
Dr.
test, ma'am.
Hasan
His
requested.
access is given to you.
Okay. I just want to see if...
I do not see Dr. Hasan online. He requested to go first, but then we can discuss this over. I just texted about that, if that's okay with you, because he has some commitments at the end of
Is it same? No, I think I have
the
to
presentation. Am I audible? Dr. Neelam, I was just saying,
You are.
the
Yeah, you
next
are.
speaker was requesting to go first before you, if that is okay with you.
I have some team here. We were just doing the scientific work What time am I leaving? Is it okay? How much is the time that he's
Half an hour
requesting?
talk. Yeah, half an
And
hour
what's
talk
he talking
between
about?
you. He's talking about liver transplant. It was sequentially scheduled
Yeah,
to
I
be
think let
after
me
yours.
finish first because I'll try to finish
Yeah,
it early.
it makes more sense to
Yeah, I'll try to finish
let's
it
talk
early
later.
because it'll make more sense.
This was a request from him, but then I don't see him around. Can we get started? There's 2 more minutes for people to gather in according to schedule we
Hey,
promised.
जरा share को देखना. Can you call him?
Yeah,
from
we can keep.
I just want to see how I can share my.
Share.
No,
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 to stop share.
no. Once I'll stop. It is this. First, I need to open that, and then I go to where is the share now?
पूरा full
Dr. Vanita,
पहले share करो बाद में
ये
full
है?
करेंगे.
नहीं.
this is
Yes,
Joel
Mr.
here.
Joel.
Yeah.
Hi.
Hi, Joel.
इसका button
And
How are
then,
you, Dr. Vanita? Dr. Vanita, I
Good.
was asking Dr. Deepak to join for a couple of minutes. I think he might come in. We'll just wait for a couple of minutes and you just kind of welcome Dr. Neelam and Dr. Hasan, and then you can start off.
can
Yes,
you
sir.
see the presentation?
Yes, yes, we can see, Dr. Neelam.
Okay. So do you want me to stop sharing now?
That's okay, doctor. Let it be on because I will not share anything. I will just talk.
Share हो गया अभी.
While we are waiting, I think
Your medical director is joining, right?
yeah, that's what Joel says. I'll just wait.
Hi,
for
Dr.
another
Ranjan.
minute.
Dr. Nalima.
Hi,
Hi.
how are
That's
you?
Dr.
I'm
Salman.
good. All are fine.
White वाला yellow वाला कर दे.
Dr. Neelam saying she would go first because
Yeah, it doesn't
she
make
has
sense, it's like, and also I have some people
she's
over
saying
here.
sequentially planned with
Mumbai
a
and
concept.
it's okay,
So
it's
the
okay.
others are waiting.
The- I think Dr. Hasan is joined or still. You are waiting for
I
Hasan.
do not see him online. If you can text him also, please.
Yeah.
Dr. Vanita, looks like Dr. Deepak is unable to join.
It's
He's
okay.
stuck.
I'll
Yeah.
get started.
Yeah. You can start off.
Thank
Nice
you,
to
Joel.
see you, Dr. Ranjan.
Thank you, and you too, Joel. Take care.
Nice to see you and welcome, Dr. Neelam. Thank you very much for coming on for this particular session.
Thank you so much.
Yeah.
Dr. Neelam, Joel is one of our core committee in the IAP AMH CMEs. Okay. I think it's time and let's get started. Good evening and a warm welcome to all. Today is the August session of IAP AMH CME session with a theme of pediatric gastroenterology hepatology. Today is our 9th webinar session and we have been going successful. The number of attendees validates our success of the IAP AMH webinar series that we are going through. I'm Dr. Vanita. I'll be the host and the moderator for today's session. Our plan is monthly sessions with the theme every 4th Sunday. And today's theme, as I said, is pediatric hepatology. We have 2 distinguished speakers and professionals from their parts of the world, Dr. Neelam Mohan from India, Dr. Hasan Faraj from Bahrain. I do not see Dr. Hasan Faraj signed in, but we will.
No, he's signed. He's signed already. He's signed already.
Okay.
Yeah,
Welcome, Dr. Hasan.
Good afternoon.
Hi, Dr. Hasan. Yeah. Before we get started, we customarily have IAP dignitaries with some introductory words. And I see Dr. Ranjan, our IAP liaison, Dr. Ranjan Pejawar, who's been the man behind the whole IAP sessions right from the planning. Welcome, Dr. Hasan. I can see you now. Dr. Ranjan, can we have a few words from you? And as always, every session has been forwarded by our very enterprising Dr. Neelam. We will hear more than forward today from her. Let's hear from Dr. Ranjan, and then I'll have an introduction to Dr. Neelam, and we'll get started with our session.
That's right. Thank you, Dr. Vanita. It is a real pleasure to have Dr. Neelam Mohan here. She's the president-elect. I think she's already started planning her year, having meetings. And as far as today is concerned, she is one of the top hepatologists, not only just of India, but even of international presence. She's very busy moving around, lecturing in the field of hepatology. We all know that. And it's very nice that she has taken time off to come and deliver a lecture here at the IAP Bahrain AMH joint webinar. The topic is very interesting. She's going to talk on acute liver failure in children, a very important topic.
Dr. Ranjan, you're muted.
Oh, sorry. You didn't hear me at all?
No, just
No, we did. Only just now.
So Dr. Mohamed Hasan Faraj is going to talk on liver transplant. I must say Dr. Neelam herself is actively involved in the transplant activities in India. She's got great experience. I'm sure she'll also give some insight, Indian perspective. So on the whole, I expect a very interesting and informative session. I do not want to stand in between the distinguished speakers and the attendees. I thank once again both Dr. Neelam Mohan and Dr. Mohamed Hasan Faraj, also the team which has been working relentlessly, continuously. We have had webinars right from the beginning, and we are now going to come closer to our anniversary in the next 2 or 3 months. So with these words, I hand over the mic back to Dr. Vanita.
Dr. Ranjan. Now I think we will get started. I do not see other dignitaries, and Dr. Neelam would be part of the panel today. The hepatology is the theme as I started introducing the seminar today. Acute liver failure is not a very common encounter for pediatricians. It's very important because of the mortality impact of this condition. So it's very useful for we plan our sessions to give insight to practicing pediatricians so that they're aware of the updates and the relevant field that we conduct seminars on. Although I said it's not a very common encounter for practicing pediatricians, it's of relevance because of the impact of mortality it is and timely interventions and the dates and the current scenarios of interventions would be essential for the knowledge of pediatricians. So we will have two back-to-back sessions, one on acute liver failure, and one of the definitive managements of acute liver failure is transplant. And the insight into what transplant scenario in Bahrain would be aired by Dr. Hasan Faraj. So the first talk would be Dr. Neelam Mohan. Dr. Neelam Mohan is a very distinguished hepatologist from India. You can see the accolades that she has. If I spend my time, it would take the whole session. So I would rather have the audience to I will share it with the audience for their knowledge later, although everybody is familiar with Dr. Neelam's achievements in India. It's for the utility of the Bahrain audience. Amongst the most distinguished was the Dr. B.C. Roy National Award, the highest award for a healthcare professional. This is awarded by the President of India. She has many presentations and publications to her credit, and we will hear from her. And she's always been present in every CME session, giving us encouraging forward for every CME session. Dr. Neelam, please.
Thank you so
Floor is
much,
yours.
Vanita. If I
Get
had to
started, please,
introduce
with-
you, I would say the lady with the best smile and the face which reflects peace and inner strength. And Ranjan is, the rock pillar who from India who actually looks into extending the partnerships across the theoretically countries' borders. Thank you, Ranjan, and thank you, Vanita, and thanks to all the audience who joined today. And since I know that my talk is going to be predominantly by pediatricians and these youngsters, so I'm just going to give you all how it is different in different age cues, the early cues, and the certain management of the new therapies. Are they just fashion or are they really evidence, and what's the outcome of them? To start with, I'll start with a case like a 7 years old girl who was having history of jaundice for a month, but it was only last 5 days that she started becoming sleepy and irritable for 3 days and actually had abnormal behavior for 2 days. Now, what I want to highlight in this slide is to show to you all that while the onset was in July, the mistake that the pediatrician made, if you see, the INR was done initially on 20th July, which was 1.42. And thereafter, he did not repeat INR. He kept repeating the bilirubin and enzymes. So unless you do INR, you will not know the child is getting into liver failure, or unless there is encephalopathy. Like this child now has evidence of abnormal behavior, irritability. So all of us know that with this, the history of irritability, abnormal behavior, the diagnosis is going to be liver failure. So anyway, with this, the child was not improving. So the child goes to another hospital instead of an OPD visit. And that's where they do the INR. They found it 4.5. They gave vitamin K, still no response. INR rather 5. This is the time they say, no, you need to go to a higher center because the child may need a transplant. But so the definition of acute liver failure is there is lab evidence of liver injury in the form of bilirubin, liver enzymes, which is either INR more than 2 with or without encephalopathy, or INR more than 1.5 with encephalopathy. And this should be within 8 weeks from onset of symptoms, like in my case. But there should be no evidence of a previous CLD in that case. So what really causes it? It can be due to virus, and we know hepatotropic viruses, hepatitis A, B, C, E. It's usually A or E because B and C majority of the time give rise to chronic, and rarely, if at all, B can present with this. And the younger babies and infants can have actually like a herpes infection, or we've heard post-COVID about adeno and CM. There was a surge of it in these, or it could be first-time manifestation of an underlying liver disease like Wilson's, metabolic or mitochondrial or a fatty oxidation. For the first time, they actually present with failure, or an autoimmune liver disease can also present to you for the first time as liver failure. And we've seen cases like dengue, where there's hypoxia, or in cases of SARS, severe bacterial infections, you can get these presentation of liver failure. And of course, drugs and toxins, like it could be either paracetamol, more commonly reported in West, and in our country, it is usually tuberculosis or the anti-epileptic medicines that you can give. Despite this, a lot of proportion are cryptogenic, and this is the data of more than 1,000 cases, which was this pediatric acute liver study group of UK and USA, and even they had this cryptogenic. But now we are understanding with the availability of genes, the newer papers, if you will see, that we've realized the NBAS gene, etc., can give rise to recurrent failure. So probably if we were to revisit, we may be shrinking this cryptogenic now. So how does it occur? It occurs because when the liver conks off, the liver's job is basically metabolism, throwing the bad things out of your body, liver and kidney. So liver is the one which is working. So now there is lack of that. So the toxins accumulate, which could be as simple as bile acids, bilirubin, or the various metabolites of fatty acids, endogenous, substances. But the most favorite theory of ours is still ammonia. So I've written bottom ammonia and lactate theory, of which we are back to this. And because of this, eventually the other organs will get affected. One of the first organs is going to be the brain. That's what is encephalopathy, because of the effect of ammonia. And once it crosses the blood-brain barrier, then it's going to absorb water, and then subsequently other organs like kidneys, and you can get into shock, and then bone marrow activity, depressed, etc. So this becomes like a vicious cycle. The more you have damage, and you further getting into it, so it's like a further damage. And this is one I'm just trying to show, that ammonia, once it crosses the blood-brain barrier, it goes and absorbs. The glutamate gets converted to glutamine, absorbs water. That's how the brain swells, and that's cerebral edema. And that, you have if it's not an infant, the skull is, you cannot expand and you can herniate, and that's what is great for what you're really worried about. And that gives rise to increased intracranial pressure. So to suspect it, it is the responsibility of the pediatrician. Why? Because a child will not go to usually an emergency with jaundice. Majority of the time, they may visit a pediatrician, and the pediatrician should be smart to identify that if there is jaundice and you have encephalopathy, like if the child is seen now, you don't need any great wisdom to tell the child is irritable, and so you say, oh wow, encephalopathy. But without that, then they would have been only an INR. And that's why I said this doctor made a mistake, because the doctor did not repeat an INR, which was around 1.5, and then C. So this is the responsibility of a pediatrician to refer to a tertiary care center, preferably with a liver transplant facility, because these are the centers which are not only geared up for transplant, but the management of acute liver failure is very effective. And I'm going to go through my presentation and show you how we can salvage much more than what literature says. So anything like this, fluid imbalance rising, or renal issue, or hemolysis, or there was a family history of a liver disease, please don't sit on the patient, just refer this patient. And when you refer, make sure that you communicate. You should communicate with the center that you're sending, so that that center can also arrange either a road ambulance or an air ambulance, depending on the distance that the patient has to travel. But through communication and maintaining the adequate lines, equipment, accompanying doctor, either an intensivist, anesthetist, or a PICU specialist with a technician is very important. Not sending just with a young MBBS doctor with some technician, and they may not be able to manage. And this is extremely important to do this. So now with adequate transport, the patient comes to me in my emergency. In the ER, we find that the patient is drowsy and reflexes are brisk. So that is the classification. My child is more than 4 years. So the classification already stage 3 because the patient is drowsy and stuporous. So I should not wait. This child should be intubated and ventilated. And right, depending on how the setup is, you may decide to do in the ER itself ABG or a VBG and some bloods while the patient is being transported to the ICU pediatric, or if there is no delay through the ER, quickly the patient can go into the ICU if the bed is arranged. Like in our patient, if we were mentally prepared with a good transport, so the patient goes quickly into ICU without wasting much time in the ER, and the basic investigations like a blood counts and the liver test and, the renal test and a septic profile, all that you do. My patient is more than 7 years, so I need to concentrate on the etiology. Already, I had the advantage of hepatitis A outside report, which was Hep A. I don't need to send all this galactosemia, tyrosinemia, that thing. Max I can send is you can do a Wilson screening because sometimes there can be an underlying Wilson which can get precipitated by a hepatitis A infection. So that's what you do. And then investigations, everybody, depending on the age, I mean, you send a septic profile, and if they were suspecting, a ferritin and a triglyceride, if you think that there was some sepsis, smaller babies, infants, you will send urea cycle, TMS, GCMS, mitochondrial testing, CPK, and all depending on the age of the patient. And if you had a drug history, you would take sample for drug sampling. So this is what you've got to do. And you may decide to take even a sample for the genetic test, like as I said, NBAS gene, they get recurrent liver failures, depending if there was a family history or a past history in your patient. The newer thing now, what is incorporated in the guideline is the transjugular biopsy. This was not there earlier. There are studies which are coming from USA and other centers where they are saying that there is an entity called hyperimmune. I mean, they're able to identify the CD8 cells and also look into the biopsies, and probably there could be a small cohort which may actually benefit by use of steroids. So this is the newer information that you'll find only in the last 1 or 2 years papers that are coming about focusing on what I said, but even the NASPGHAN and the ISPGHAN guidelines talk about using a transjugular biopsy in case. But my case, I don't need. I have a hepatitis A. It is more often done when you are cryptogenic in that case. So what is the circle of care? This is the circle of care. I have to revolve. A good management is to write look so simple. You think anybody, even a physician, a pediatrician should be able to take care. But if you ask me, the fluid and electrolytes, literally you have to be very careful in an ICU setup, and hourly monitoring of this can make the big difference in a patient, because too much of fluid and too less, I will show you, can give rise to problem. So you're looking at fluids, you're looking at electrolytes, your coagulation profile, your ammonias, and at the same time, the lung should not get overloaded, your kidney should be working, early CRT, and prophylaxis for sepsis, infection. So my patient, since the patient was stage 3, as I mentioned, stuporous or drowsy and hyperreflexia, I should not wait, a quick intubation. And what happens if I give more fluid? I'll get into congestive failure, I'll get into brain edema, I'll get into liver congestion and kidney overload and pulmonary edema. What happens if I get less fluid? I'll again have tachycardia, and I'll get lung injury, I'll get acute kidney injury and less cerebral perfusion. So that is why that is the expertise and the key where you need to monitor like a hawk the fluids that you're doing. And now we use the POCUS point of care ultrasound. We keep looking at the IVC of, to see what is the fullness of fluids in that. and you would use, usually they require more potassiums because the potassium in liver failure goes bad. And you not only maintain your sugars range, your sodium should be 145 to 155. Ensure you don't get into hypernatremia, and please ensure phosphate is also, because ATP, energy, reactions, you need to be. So phosphates often get low and is often missed by people. So mention that you can use oral or Joule's phosphate. And this is what I'm saying, that there has to be an ultrasound in your ICU so that you're able to see how your IVC is there ascites, what your diaphragm is there pleural effusion. All this you're able to see yourself how you're managing. So my patient now has an ammonia of 145 and an INR, which was not recorded because the test said more than 200, and bilirubin was 32 milligram percentage. Lucky the renal function test were okay. So this is a patient should go immediately for a CRT. Now I'll show you why. So in this case, I can go in for an EG, a bedside CT. I need to ensure that the head and raise, quiet room, not frequent suctioning, use lignocaine orally if you want to suction, lactulose, rifamycin. Lola is not really suggestive, L-ornithine, L-aspartate for acute liver failures. There is some role in acute or chronic liver failures. You need to be careful because any infection, any hypotension, any bleed, any renal dysfunction, any electrolyte dysfunction will worsen the encephalopathy. And your brain is the control for everything. You have to save the brain before you decide to change the liver or control the liver. So therefore, it gets very important. And the dictum is it's not give zero protein because then the muscle breakdown will occur. So give anywhere close to 1.8 1 grams protein and do not cross that. And this patient, we like to do the optic nerve sheath diameter, which if it is more than like we have ranges in the age less than 4 and 4.5. So my patient's optic nerve sheath diameter was 5.6 and 5.4. So that's pretty high. And what are the recommendations? We've come out with the guidelines in India, besides out, where we are saying that, yes, this is useful. Optic nerve sheath, we do transcranial Dopplers. We can even look at reverse jugular venous oxygen saturation, and I'll show the machine next. So that is the diaphragm picture I'm showing you here of the optic nerve sheath diameter. What is this millimeter I'm reading here? And then the transcranial Doppler I'm seeing through this port. We need to see what is the oxygenation blood supply going up. So this is very useful for me to understand how the oxygenation is going on. Bolts, we don't do so much now. It's out of fashion. Earlier, we used to do the bolts, but it does not change the mortality. So therefore, because of the risk of bleeding that has down now, we like to use the optic nerve sheath and transjugular. So you have to put the patient into cerebral and measures ventilation. There's no clear-cut guideline to say that you should give anti-seizure. Of course, you find some abnormal movements, then you're justified. Mannitol, if your kidney test like my patient was okay, so I should give mannitol and start with a hypertonic saline. And occasionally, if you're you're having this thing, you might want to use hyperventilation to keep your PCO2 in the lower range. There is no dictum to give unnecessary FFP. This is a key message, that unnecessary use of platelets and FFP should be avoided. Only if you think your fibrinogen is low and coagulation is very high, yes, please go ahead giving cryo. And very rarely for bolts, we've used factor 7, not otherwise. And we need to monitor the kidney test and start CRT. So what is the new game changer according to me? The new game changer is the early CRT. This is something I feel has been a good, kid around the block, which helps him. And remember, nutrition should be looked into. And usually you are able to, if you're not on inotropes, you'll be able to start with enteral feeding. And this is my patient. First, INR was very high and I had to put lines. So I would give FFP because I need to support it with lines. And subsequently, now this patient, I know now the challenges is when to transplant and when not to transplant. So this patient, INR was more than 6 and, 3 readings, outside reading, our reading, encephalopathy, high ammonia. So this patient would satisfy the criteria, as you can see, for liver transplantation in this. And there are other criterias, but still a lot of us use the two criterias like King's College and the other Clinchy. It's beyond the scope of this talk, and I can answer questions. What are the challenges of an ideal score? There's so many issues. We still don't have a classic ideal score where I can say 98% that you will die if you don't do, or 98% you'll survive. Nothing like that. Everything is 80 and 85. And this is where your wisdom comes in. We've put in a paper in a PASL where we showed that adding AKI, kidney injury, was useful along with the King's College criteria. You don't transplant when there is a neurological damage and the pupils are, not reacting, multi-organ failure, sepsis, extrahepatic malignancy, something like that. That's when you don't. Otherwise, in this case, my child was O, mother was O, father was B, but my mother's enzyme are high. So with this liver enzyme high, she cannot donate. And in India, we have predominantly living related. We don't do much cadaveric transplant. So I have to put her on hepatic support, like start with CRT and consider plasmapheresis as a bridge to therapy. In this case, mass is now outdated. With the cost that you give, plasma and CRT have better results. So I wouldn't put the other two down. And what are the guidelines for ALF? An absolute ammonia of 200 or more than 150 and not getting control, and more than 2 encephalopathy. And my patient definitely had lactates high, ammonia high. So we go in for this plasma exchange. Again, we showed in that, especially in hepatitis A, where you're waiting for the liver to recover. In such there is indication as a bridge to therapy to use, especially when there is hemolysis, like in Wilson's or yellow phosphorus 2, or in Hep A. So this is the paper, and you can see I'm supporting this child with plasmapheresis, with CRT, and this is what I talked to you about, the jugular venous oxygenation, non-invasive this thing, monitoring, bedside CT and everything, till the mother's enzyme improved and she was fit enough to donate. And then a week down the line, we could use the mother. And the zenith of satisfaction was when she gets up and she remembers her name and she says, my name is. So that is when you feel, oh, my upper story is okay. So what are the lessons I've learned? We presented I'm writing a paper on 412 cases of liver transplant, but this is where I'm showing, I think, 390 cases or so, that infections are the commonest category, 47% with us, followed by 25% cryptogenic, 21% metabolic like Wilson's or tyrosinemia, and others like autoimmune. And in the infections, it is hepatitis A, E, or even dengue is a huge amount of infections that can give rise to liver failure. And our spontaneous recovery was 65%. Now, what am I trying to say by this slide? What I'm trying to say is a good management can help you to get a good medical treatment, also can survive 65%. And in our center, we have not only 1:1 nursing, but we have an ICU with a separate Within the ICU, we have beds of liver failure. So there is one resident who's actually looking only after liver failures, liver transplant. So the outcome is better in this. And we've come a long way in 20 years. The first transplant in India was done in 2004, 9 September. That's when I salute this mother when she donated. And this boy is now, 25 years down the line. We are 21 years down the line. And I have been very fortunate to be the right person at the right time, where our team was had several milestones. The first cadaver transplant in India in 2003, the first combined liver kidney transplant, the first liver failure, the first swab transplant, the first robotic transplant, the first blood group mismatch transplant, the first hepatopulmonary, and I'm also happy to share that this was really history to get the swap done, and parents can swap the livers in terms of need to, because it's not exchange of money, it's exchange of organs. And this is robotic when you don't get any scars. And blood group mismatch in India for the first time, not only children and adults. This was a girl where we did the and then now it's routine that we do a lot of blood group. I think our team got into global scenario with the youngest domino in the world. This child was MSUD, where we took the liver of this and gave to another child who was sclerosing cholangitis. That is called domino. The liver was having enzyme deficient, but the enzyme normally is in the muscles like in the other patient. So these two girls are children are doing so well. 15 years down the line, they are, he's doing CA and law. And this is hepatopulmonary syndrome. She was on ventilator for almost a week. And I'm privileged with the brilliant team that I have. The lightest baby in the world, 2.16 kg, was done by our team. As you can see, I'm holding her in my hands itself, like such a small baby. And the world's first dual liver transplant in a child was done by us, where these two sisters, this child was 90 kgs. So not one liver was sufficient. So we had to give two parts because the volume was not coming. And this was also...
Sorry to disturb you. You have 2 minutes.
Yes, I'm finishing. And that is swab transplants. And they are 10 years down the line. We have a lot of patients. The patients who have now produced children, because a lot of people ask, can they live a normal life? Can they have children? And our success rate was fortunately pretty high because it's a living related center. So to sum up, ALF, our goal should be to prevent the brain edema, to prevent you from infection, bleeding, fluid imbalance, electrolytes, and monitoring like a hawk, as I say, is the key to that. Early transfer, safe transfer, early recognition, early CRT, early plasmapheresis, right timing for the transplant. All these are very essential, and the outcome of transplant in good centers like us are pretty good. And I acknowledge my entire teachers, my mentors. I trained in UK and in All India Institute, and all the team who supported me in this endeavor to achieve the transplant services in India first. And now I'm proud that 45, 50 of my students have gone everywhere across the country and are doing great work. Thank you for having me over.
Thank you, Dr. Neelam. That has been an illustrious journey which we got to witness. And in the meanwhile, we got to know about the hepatic failure and our commitment as to how to go about it. Dr. Hasan, sorry for keeping you waiting. I understand you have some commitments. Can we have you over here?
I was enjoying Dr. Mohan talk, actually. Yeah.
Welcome, Dr. Hasan. Dr. Hasan is our next speaker. Dr. Hasan Faraj, we are all familiar with Dr. Hasan Faraj. He is a distinguished hepatologist, gastroenterologist from Bahrain. He is the senior consultant hepatologist, gastroenterologist in Salmania Medical College. He's trained from Australia, and he has similar gloriful publications to his credit. I do not want to keep him waiting, and I want him to get started. He'll be talking about pediatric hepatic transplant stories from Bahrain. Dr. Hasan, please.
Yeah, thank you so much actually for that nice invitation. And I was actually, Dr. Mohan made my job so easy now because she gave lots of details about the acute liver failure. I don't know if you can see my slides, or is that?
No, you're to share, doctor. Can you share, please?
I'm sharing. Dr. Mohamed, can you help us on that, on the technical part? Yeah, I'm trying to share.
There is a share button below your profile.
Yeah. I know that.
Yes, you're in,
Yeah.
doctor. Dr. Neelam, we'll have a discussion after the talk. So please stand by till the end of Dr. Hasan's presentation. Thank you.
So, okay. So can you see my slides now?
Yes, go ahead.
Okay, great. So now I'll be talking about liver transplant in Bahrain because it's a small country with 1.7 million only. It's not like India where you have like the privilege of having centers for transplant. Now, and I'm sure that most of the countries worldwide, especially the developing countries, they don't have centers for liver transplant. So I thought, why don't we share our experience here in Bahrain? How can we handle cases with acute or chronic liver diseases in which you don't have a center to help you? Now, as a background, we will say that liver transplant, we know it's a life-saving procedure for patients with end-stage liver diseases and has become the standard actually and most effective treatment approach nowadays for these patients. And we know that there are so many indications for liver transplant, and they are different between countries and different settings. And the outcome also will be different according to the available facilities, how the surgeons, the expertise of the surgeons, as well as the type of liver grafts, the donors, and the availability. Now, in general, like we know that the first transplant that has been carried out worldwide and was successful in 1967 by Professor Hartz. And then after that, since that year, the liver transplant is almost like spreading worldwide. Now, in Bahrain, we are collaborating with different centers in in India, Turkey, Saudi Arabia, Iran, and recently also in the Gulf countries here, Kuwait started to establish like their first patients with liver transplant, and also Oman. However, most of the developing countries, they lack these facilities, and their patients will either die from complications related to acute or chronic liver disease, or if they are lucky, they will have a suitable donor. And the only way for them to survive is to send the patients overseas with their donors to have an relatively expensive liver transplant. And that's the case actually here in Bahrain. So far, we don't have the center, we don't have the facilities. What we have is actually the pre-transplant care, post-transplant care. So that's the option for our patients. Now, since the 90s, the Overseas Treatment Office here in the Ministry of Health, they are sending pediatric and adult patients with end-stage liver diseases to go overseas, provided that they have their own like a suitable donor for them. Now, and this arrangement is like a multidisciplinary, in which we have the consultant would write the letter and then send it to the overseas committee. They will study the case, and they will send letters to Turkey, India, and Saudi Arabia mainly to look at the patients, and then the one who like agreed to accept the patient we will like do the more work to send them overseas for the treatment. Now, so we started reviewing our patients. What was their like clinical characteristics? What is the indications for transplant, medical therapies? What are the complications and the outcomes of pediatrics and adult patients from Bahrain who required liver transplantation? Of course, we looked also at the possible predictors of survival among this group. So, in a retrospective cohort study, we reviewed the medical records within Salmania, which is the main hospital here in Bahrain, and also in the overseas committee registration information. Like we look at the files and we try to get information. It wasn't easy to get, like from 1997 till 2023 to review all this data and see like how many of the patients being sent overseas for liver transplant. Now, so we included all those patients who actually underwent liver transplant, and we excluded those who died before transplant, or those who are still in the waiting list, or those who are missing very important relevant data. Now, we collected the data from paper-based medical records and the electronic medical records, as well as the overseas like committee registry. And we tried to communicate also with the patients by direct calls after they finished their liver transplant, or the parents of the child who had a transplant. Now, we did the statistics for our patients, describing their clinical characteristics and looking at the survival using Kaplan-Meier curve. And we tried to look also for the predictors of survival using univariate and multivariate analysis. So, and this is the result. We were able to collect 208 patients who've been listed for liver transplant. Now, 38 been excluded because 20 of them, they are still on the waiting list. 14 died before they've been sent to overseas, and 4 had missing data. So the remaining are 170 patients who've been sent overseas. 167 of them, which is 80.3%, were adults, and 3 actually underwent liver transplant. 3 again died in the center while they are waiting for the liver transplant to be done. Now 47, which is around 30% of them, they were pediatrics, and 71% were adults. And this is the cohort of our patients in Bahrain. Now, when we look here at the clinical characteristics, you will see that the majority of them were adults, and 57% of them, they were males. So the majority, like most of them, they were males, and majority, of course, would be Bahraini, 91%. And the age of transplant here, the median age was 50, but in pediatrics, it's around 4 years. In adults, around 55 years. Now, what were the main indications for liver transplant here in Bahrain? In pediatrics, we have biliary atresia, which is not surprising, biliary atresia, followed by progressive familial intrahepatic cholestasis and metabolic diseases. While in adults, hepatitis C is the main indication. Now, who were the donors for the patients here? The majority, actually, they are living-related donors. First-degree relatives are the most common, both in pediatrics and adults. However, adults receive more cadaveric than pediatrics. So, based on our community, the majority also, like other Asian communities, they do prefer to donate for their kids. And yeah, so I might move here faster. Where are the centers here? The centers majority will be in the Middle East. Of course, we have the 3 main centers: Turkey, Saudi Arabia, and India. And you can see here that 70 patients went to India, to Turkey, while 22 in Saudi Arabia and 52 in India. Now, for the medications post-transplant, tacrolimus was the most common, followed by prednisolone, MMF, and etc. So we have here and we noticed that steroids used more with the pediatric patients than adult patients. And that was statistically significant. Almost 62%, they developed complications post-liver transplant. And the most common complications are infectious episodes, which is also not surprising, being undergoing major surgery, and also the infection is high, and they will be immunosuppressive medications. So tonsillitis is the commonest, followed by sepsis and acute gastroenteritis. For the non-infectious complications, biliary strictures and rejections comes at the top. Yeah. So in terms of survival, Now, the overall survival rate was 84.4%, and the 5-year survival was 86%. Mortality is around 15%. And actually, the pediatric, they give better survival than adults, though it was not statistically significant. Now, in terms of analysis for the outcomes, we noticed that the younger age group is in favor of better outcome as they are younger. And I will this slide shows the success rate among different centers. However, this has to be taken with caution because the numbers are different. Now, 100% for Saudi Arabia, 88.2% for India, and 76.1% for Turkey. Now, and in terms of univariate and multivariate analysis, we looked at the different predictors of survival, whether the sex, the nationality, the governorate, the age of transplant, the group, whether pediatric or adults, their weight and height, present associated diseases, like the type of donor, the indications like hepatitis C, biliary atresia, and the presence of complications. Now, we couldn't get a specific predictor. However, we know that those who went in the Middle East centers, they give better outcome. Now, comparing our results with the international figures, we noticed that most of the centers, they have higher pool of adult patients, which is expected, as most of the centers, they will start with transplanting adult patients, and then when they got experience, they will move to pediatrics. So this is comparable with other studies. Now, in terms of indications, biliary atresia comes at the tops in most of the countries compared to USA, for example, Europe, Korea, and Japan, and Turkey. The majority, the biliary atresia. So the biliary atresia will be the most common indication, and this is also comparable to our results. Now, in terms of adult indications for transplant, hepatitis C remain almost universally the indication of adult transplant. Now, for the types of the donors, we have the living donor and the diseased donors. It's difficult here for country like in the Arab countries to go with the diseased donor because of social, religious, and cultural reasons. So the living donation is the most prevalent, and this is understandable. But maybe in the future it will be changed. Now, the most common type of graft is the living related graft in 82% in our community, while it's the same almost 84 in Korea, 45 in Canada, and Turkey 32. Okay, while in Saudi Arabia, the cadaveric grafts are more, here is 63%. Yeah, it depends. If you have a center, you will go more with the cadaveric, while for us, we prefer the living related donors. Now, in terms of the related grafts, the majority, the pediatrics have more related grafts than the adults, as we mentioned earlier. Now, immunosuppressive medication, like any other center in the world, they use mainly tacrolimus in 84%, while others, they have it in higher or lower rate. Now, the complications, like 62% of our patients develop complications, infectious complications, which is also going with the international, actually it's higher than the international figures, and we attributed that to the manipulation, technical complications during surgery or the immunosuppressive medications that we use. And the survival rate, now we have it 82 or 84 as the overall, and 86 in 5 years. Okay, and that was not different between pediatric and adults, but the pediatric gave better survival of 89 compared to 82%. And other studies, like for example, Adam et al. Here, they give 5-year survival between 79 and 70. So you can see that there are differences between centers according to the survival. There are so many variables, and this is also understandable. However, in general, liver transplant is a life-saving, and we have no other options. And in general, compared to other types of transplant, 80 or 90% is considered fantastic. Yeah, so Younger age group will give you better effect on the survival and the long-term follow-up. Now, in Bahrain in 2020, in collaboration with Saudi Arabia, a team came from Saudi and they started like doing the liver transplant, and they were successful to transplant one like adult who was 20 years old with autoimmune hepatitis, and it was a successful transplant. And recently also I hear that there are few like couple of patients being transplanted in Bahrain, but still we are building our experience, and we know that we cannot like substitute like the collaboration with other centers worldwide. So in conclusion, that acute and chronic liver failure are conditions that has high mortality rate, and we know that we can save patients with doing liver transplantation for both pediatric and adults. Collaboration between different centers are very important, especially with you in India, and we know that you've been helping us on our patients, and the results are really fantastic, to be honest. And the donor issues will stay. Always there is a donor shortage, and we need to overcome this challenge. Anyway, we published our like results in the World Journal of Transplant, and thank you so much. I think I will leave you with a video for one of our patients. Okay, 1 second. So you can see the journey of liver transplant. 1 second. How I can escape this? Stop sharing. I'll stop share this. Yep. Okay. Hello.
Yeah, Hasan, just again, sharing your slide and open the video.
Yeah, I'm trying. 1 second.
Yeah, sometimes it takes a second. Don't be hurry. Just wait.
Yeah, the video is there. I mean, but where to go in Zoom?
Go
Yes.
to sharing.
Yes, I'll go to sharing, and then I will go to that. Now, can you see it or still?
No, still.
Not yet, doctor.
Still.
Yes, now
Okay.
you'll be able to share.
Yeah, okay. So can I start? No, 1 second. Oh. So I'll stop sharing once, just bear with me because I'm trying.
No problem, no problem. Take your time.
Okay. Where to go? So share the screen. Oh. So I will share this. No. Do you see it? No?
Yeah, you can.
Yes. So that's the video, and this is the journey of one of our patients. So his name is Ahmad, and he had like
end-stage liver disease has lots of consequences, especially in the children, such as development failures. They cannot go to school. They cannot go to public places, and they have lots of type of disorders that can cause other side effects. And the only treatment for this liver disease is liver
In what center this one, Dr. Hasan?
Liver transplantation
This
has
is
been done
Turkey.
really successfully in our institution for many years, and especially and also in pediatric patients. In our patient, the patient was severely at end-stage liver disease, has lots of problems, malnutrition, development problems. After liver transplantation, this patient treated successfully in every place. Liver transplantation can be performed from living donor or brain dead donors. In this setting, Ahmed was transplanted from his father as a living-related liver transplantation. In this living transplantation, it is a gift. We consider this as a gift for life for every person who has received transplantation. After transplantation, Ahmed has done well, and liver graft worked properly. As far as we concern about other things, we assume that after he discharged from hospital, he will be as good as and as normal as other children, and he will be social as he likes to and wherever he wants to go to. After liver transplantation, Ahmed is now in healing process, and after he discharged from hospital, he will be much better. He will feel much stronger, and he will be more normal as a children after he discharged from hospital. Thank you very much.
في البداية بسم الله الرحمن الرحيم. معكم محمد عيسى علي، والد الطفل أحمد محمد عيسى علي، وإحنا من البحرين. وقبل سنتين تقريبا والدي ما كان في شيء الحمد لله، فجأة صار اصفرار في العين وصار اصفرار في الجسم كله، ووديته المستشفى في البحرين وتم فحصه، وما كان ما كان عندهم العلاج، يعني ما قدروا يسيطرون على الوضع، فحولونا مستشفى في تركيا، المستشفى اسمه فلورنس في اسطنبول. ما قصروا طبعا، الدولة ما قصرت في البحرين وجابونا على حسابهم الخاص، والعلاج كله على حساب الدولة، واشكرهم، انا اشكرهم يعني شكر كثير. وطبعا اشكر المستشفى هنا في تركيا فلورنس، واشكر الفريق الطبي كله، واشكر المستشفى من معاملة ومن علاج ما شاء الله. اشكرهم يعني شكر وايد اشكرهم. الحمد لله.
السلام عليكم ورحمة الله وبركاته. مشكورين ما قصرتوا، مريض شافيتوني، يعطيكم العافية.
Yeah, so yeah, that's interesting. Yeah, so this is one of the successful stories. But
when was this done?
Yeah, I mean few years back. Yeah.
Few years back. And how's the child now?
Yeah, he's okay. However, the compliance is not great as expected. These patients they need to be monitored at the end. Yeah. Hello.
Yeah, we hear you, Hasan. Continue.
Yes. So yeah, we need these patients to have better compliance, because even sometimes the social circumstances, the parenting, all these factors, they can affect their outcome. But yeah, I mean, we have so many success stories, not only this child, and from different centers, and we have like great experience with collaboration with centers in India. And so that's why we are living in one village and each one is helping each other. Yeah.
You can stop sharing also the slides.
Yeah, sure.
Yes, Doctor.
Yeah.
Thank you, Doctor. That was a touching story as well. The experience of Bahrain was informative, statistics and details. Thank you, Doctor. Apart from the discussion, we were focusing on acute liver failure. Dr. Neelam, can we have you back in? Can we take some quick questions from the audience? I think Dr. Hasan has some commitments to fulfill. It's about time for him to leave. If there are any questions from the audience, the emphasis was not just the transplant and the post-transplant care, which Bahrain takes full responsibility of the patients who have been sent for transplant. This is what Dr. Hasan was saying. The whole fruit of labor is in continuation of care after the said procedure. That's what Dr. Hasan was emphasizing on.
I think I would totally emphasize on what Hasan is saying. I always say that transplant is not a procedure. It's a journey. It's like a journey. You need to get connected to the family and to know it's not like you know, most of the sometimes, you know, the younger generation and centers, some of them think, oh, our transplant is successful. After that, they are not sure what is happening, whether there are any biliary issues, what are the outcome. So absolutely, as Hasan said, you have to ensure that they are, and that's what, thanks to digitalization, you're able to now communicate, do video connects, and you know, life is so much easy. I think about people who lived 20 years back who were practicing, you know, how difficult it must have been for them when they had to go to, मेरी battery खत्म हो रही है, वो दे देना. They had to go to you know, international centers and not get care. So that is an advantage now with digitalization, that they can still go back to the, you know, to the doctors and communicate and discuss.
Exactly.
I have patients whom I discuss with the referring doctor, like Iraq and those centers we do get, and I do discuss with.
Yeah, actually, if you allow me to add more points here, especially with the acute liver failure here, the condition might not of the patient might not be that much, you know, easy to transport. So yeah, so as you said, you know, the use of online consultations and trying to manage patients remotely will be very, very helpful for centers where the transplant, you know, facilities are not available or they are remote from them. And I don't know, how do you handle patients with acute liver failure in India, for example, in like the transportation specifically? Yeah. Dr.
Yeah,
Mohan, if you can
the
just...
acute liver failure is a total different game. The critical care is of the vital difference there. And the as Dr. Hasan is saying, that would be the logistics issue of the critical care in transit, which would be Dr. Neelam showed a profile of how they handle across India. India is a diverse nation. You can imagine the difficulties that are encountered in transportation in India.
Exactly.
Such relevance can be extrapolated to any situations in Bahrain. But again,
you know what
Bahrain's
happened? Yeah, I remember we had a girl who was nine years old. She was from different country. I shouldn't mention it, but anyway, she was admitted in Bahrain and with acute liver failure, and we told the family obviously that she needs to be transported to a liver transplant center overseas. Now the family were not convinced, and they took that girl, covered her with the clothes, and they book a flight for her, and they flew, and then there in the airplane she died, you know. So yeah,
No,
because
normally the planes nowadays make it a point. They need a fitness certificate from the referring place. Like I remember initially we had some cases from Nepal, Bangladesh, Pakistan. Those days I'm talking about. We do remember in India one airlift from Pakistan. In fact, two airlifts we did from Pakistan. So it is very important that you, when they do it, you should talk about air ambulance, like I showed in our place, air ambulance. Without an air ambulance, like, you know, the center where I'm working from 2010, 2010, 15 years I've been in Medanta. We have an air ambulance since then. So without that, it gets very difficult, especially in such scenarios. We've marched a long way, and I think that is a way forward where the pediatrician should understand that there is no point referring a patient in stage 3. I repeat, do not wait for the patient to get bad to refer. That is the beauty of today's talk, where we are trying to highlight that don't wait till you think the patient is bad. You should actually ask them to go, if they are affording, to go to a center where there is good care. When your INR is gone above 3, or your you know, the finding a child irritable, please send them to a center. Depending on, obviously we are not you know, I mean, we can just plan good for the family. Ultimately they can decide, and if they can afford it, that's when they go. And it's also a important thing for me to say, like, probably transplants in India are 1/10 of USA. So that's what they save in a transplant, but at least the transport, they should not try to, you know, get into a normal flight, because that's where you're going to have a problem. There was one flight, one patient I remember, that is also allowed by some airlines, that you can buy 3 seats or 4 seat, and they have something like an ambulance in a normal flight, not an air ambulances. The air ambulance is a small craft which gets only the patient attenders and the, you know, a referring the doctor. But even in the domestic, like say Air India, so you can buy 3 seats and put it, but the patient is intubated, ventilated, and with an accompanying doctor. But then still, when you are going up in the air, there can be a risk of bleed. And that is why some of the airlines have now refused accepting them.
Okay, to summarize, the point in transporting for hepatic transplant and acute conditions would be only with debatable trigger points. What would you suggest the inflection point, doctor, to suggest transplant as an option? I know criteria like King's and all are not serving our purposes here. You told about the utility of those extrapolating to pediatrics. That's not so much our thing. So as a summarizing, what would you suggest, and what's the time point you would suggest we would foresee or predict need of transplant and look forward for it? And most times we will not be able to go about it. It is all an acute situation. We always land in a critical scenario. And when we have a critical scenario, like a place from Bahrain, doctor was telling, most of our situation is to coordinate with centers who manage transplants. So how would you think the feasibility would be for us? Can you propose one set of criteria where you would think the inflection point is, set of suggestions, although there are no fixed guidelines, I know. And what would you suggest the medical management, which should be comprehensive prior to this? And Dr. Hasan can just streamline for the centers who are non-Salmania to summarize the points where we decide it is time to get it into your zone for you to coordinate. I understand you have mature plans of coordinating with the requisite centers to handle these situations. So Dr. Neelam, can you please summarize the suggestions for us? And followed by Dr. Hasan, you can top up the needs.
Hasan, do you want to start first or do I?
It's up to you.
Okay.
Yeah.
So I'm extrapolating it for you. That's why I thought I should seek your permission. So I think number one, I assume that facilities for a good critical care management, except transplants, are available where you know. So I personally feel that there are, over the years, as I said, 412 cases where only from the last 15 years. Before that, 10 years were a different institute. So I mean, I've had great experience even there. So what we realize, and the wisdom that has been there for last 25 years, is that if the patient is infection, like hepatitis A especially, there are higher chances that they'll come out with good medical management. And the recent one in our setup, 80% plus we can salvage with the use of CRT and plasmapheresis. That's number one. Number two, you should not, the critical care management is what, as I said, majority of the time people are failing to understand that when it is liver failure, they just think that, you know, it's like any other patient in the ICU where you just see 3 times a day, and if they are on ventilator, and that's enough. It's not really enough. You literally, I said, you need to monitor like a hawk. So you need to be monitoring what's the urine output. You need to be seeing more frequently. It could be as frequent as 4 to 6 hourly initially, the sodium, till you're comfortable to get into 6 to 8 hourly. You need to be checking what your IBC is. You need to be checking, the phosphates and the sugars and everything. No bleed, no infection, no extra stimulating the patient, because these are the ones which are going to make it more susceptible. And if the patient has jaundice encephalopathy ratio, which is short, I've noticed in quite a lot of them do come out, even if they have hyperammonemia, giving good CRT in the beginning, that salvages them. The key point is you should not allow your lung and kidney to conk off to fail. So at least the lungs, they are very important, and starting inotropes initially because they have white pulse pressure. So that's what you do. But if the patient says that they are affording and they just want to be in the right center, and if you have issues that you need to send it to a transplant, which is, maybe far, maybe this, then if I were you, I would probably ensure that in grade 1 encephalopathy, or anybody who's getting into high bilirubin with an INR, more than 2.5, 3, I would consider them a transport. Because once you have encephalopathy, then you have to intubate, and then that the transport gets difficult unless it's, I don't know, do you transport by road or by air? How do you transport, Hasan?
No, by air.
Across
By air.
Yeah,
continents
by air.
yeah.
So then that is why I would not insist you all. I mean, sadly, there is no way, you can be 80% right, that's what I'm saying, and you may end up making an error judgment in 1 out of the 5, and that may not be acceptable to family. And you've got to be honest to say that sadly we don't have any one criteria like a thermometer to say 103-degree temperature. It is a collation, it is the age, it is the type of infection. Suppose it is Wilson's, for example, without encephalopathy.
Etiology, yeah.
And then I may be able to do good with plasmapheresis and chelation if it is without encephalopathy. But if I have a Wilson's whose INR is 6, then I know I won't be able to chelate for 3 weeks, plus this child may not survive. So I should say. So you need to identify. Infections do better than metabolic. And I would request, I hope this paper gets accepted, where I've talked a huge thing about not only the secondary objectives, the primary, the outcome, the criteria, everything I've talked about in that. I'm writing that paper, which is yet to be accepted, which is going to give the experience that we are talking about, how these can be extrapolated. And your kidneys, if you are having marginal, as I mentioned in one of my slides, if you think there is a family history of a death or something like that, if you think that there is a patient where you're having some renal issues or on spot immediately. Don't wait and think, I may be able to salvage. I know you may be able to, but you're not going to do it 100%. You're going to do it 65%. That is in my sentence. But if you read new papers, they say that more than half, they cannot survive. That is with the best of literally 1:1 nursing and doctors, I'm saying, with, POCUS and all. So there has been a change. If I see myself, what I did 25 years or 20 years or 15 years down the line and what I'm doing now, I think I've changed a lot. I'm using more plasmapheresis, I'm using more CRT, I'm using more optic nerve sheath, I'm using more these type of measurements, jugular vein and all. So I feel I'm more in control about understanding the patient now than earlier, where I would just, sit for an angel to come and decide right or left.
Yes. So, yeah, and from my side now,
Hasan.
yeah, I totally agree with you. But you know what happens, especially in our situation here in Bahrain, most of the doctors, if they face cases, I think we start with the basic things of diagnosing or looking at the red flags here on patients who might deteriorate. Now, having, as you said, coagulopathy or, started deterioration in neurological functions, then immediately we have to take like a quick action that we refer at least these patients to secondary or tertiary care, in which they will, do the stabilization of the patients and started communicating with the centers overseas, or recently also we have some expertise in another hospital, the King Hamad Hospital. We can communicate with them. Now, my message here is also the prevention is important, because we know the indications for transplant in pediatrics and adults is going to be changed. And, the muffled or NAFLD, non-alcoholic steatohepatitis, because of the obesity and the pandemic of obesity that is going on, it will be, I think, the first indication for a transplant. Handling such things should be taken seriously from now, because most of our kids now are becoming obese, and we have to watch their liver functions before they deteriorate and went into cirrhosis. Yeah, so I mean, I know the worries in countries where we don't have centers. What do we have to do now? Yeah, we have to be honest and frank with the parents that the patients will need to be transplanted as soon as possible, and our job is just to stabilize until things been arranged. Yeah.
That was very well said. And if I may put in a point, so actually in MASLD, now we call it not NAFLD, we call it MASLD, metabolic associated steatohepatitis liver disease. What exactly I would say is you need to understand the etiology first. So MASLD will not give rise to liver failure in childhood usually, because it takes 15. Having said that, I agree with Hasan that couple of reports of patients getting into cirrhosis and all. But what is very important for you all to understand, that basically God has given you more than the liver is actually more than one. What do I mean? What I mean is that you've actually got close to 50% reserve. So when for any reason your liver fails and that is not working, it's your reserve which is working. So what Hasan is saying is that with this obese and with this steatotic liver disease, this reserve is already fatty liver. So the patient may be having 30-40% fat. So that means when there is necrosis going in this, there is no reserve. The patient will get into liver failure. Will deteriorate because there are no there. So the etiology could be cryptogenic, could be infection, could be anything, but the patient has no reserve because fatty cells are not normal cells. Fatty cells do not work. So the patient is already living on 60%. There's a confirm, he goes off.
Yeah. So the focus is on prevention and
so therefore prevention, as he said, is two. One is that, and second is hepatitis A vaccine, hepatitis B vaccine. My message is hepatitis A, hepatitis B, and prevention of fatty, as he rightly said.
Okay. I think Dr. Hasan, as he mentioned, his
I have a clinic. Yeah. So,
thank you, Dr. Hasan, for
thank you.
Okay, we can take one picture with Hasan and me together. I don't know whoever. I can't because I'm on a phone. So let us ensure that we can admire and say we were together.
Yeah, thank you. I think we can manage that. Yeah. So we have a recording which will be shared with you, Doctor, later.
Hasan, we need to get in touch together after this.
Yes, sure. I think, as I always say, the perk here is our communication and the point that we've made, the audience as well as amongst us as to when and how we should react. And this collaboration is going to go a long way in helping us at the right juncture.
The others enjoyed the talk. I would be very happy if you can put in a message in the chat box, because it helps us to improve and to deliver more. So I speak on the leadership hat of IAP. Do message, do voice to our Ranjan and to communicate about how things are. And on behalf of IAP, I sincerely thank the leadership in Bahrain for doing this, because knowledge exchange is one of the early steps to improving healthcare. And it's like exchange of knowledge is extremely important. There was so much to learn from what Hasan had to say and what I had to say, hopefully, to you all. And we look forward for further future endeavors in empowering a child with knowledge, because globally, children anywhere and everywhere are very dear to us. And we work as pediatricians to ensure that every child anywhere, we try to improve their health. So thank you once again for giving me an
Thank you.
opportunity today to be amongst you all. Thank you.
Yeah,
Thank
thank
you,
you,
Dr.
everybody.
Neelam.
Thanks. See you later. Thank you.
Thank you, Dr. Hasan.
Bye.
Dr. Ranjan, can you sign off, please? Can you share
Yeah.
your wisdom
See,
before we sign off?
I'm speaking as a mortal neonatologist. I learned a lot today. I learned hell of a lot today. And the talk was so brilliant, both of them. One gave a very current, apt way of handling impending liver failure, and followed by possibility and executing a liver transplant. Everything was covered. Dr. Hasan took time to pull up the statistics about Bahrain transplant history and the transplant program. That was very, very informative. And the proof of the pudding is the number who have attended right from the beginning till the end. It's very close to 300, which is a big number, I feel, on a Sunday evening. Of course, you are in there, it's working day, but still, the interest shown in this program is amazing, and it's going on very smoothly, thanks to Dr. Vanita, Dr. Salman, and the team of AMH who organized this thing. IAP, of course, is doing a great job. They have so much to cover, so much work to do, but still they manage the platform very well, and everything is in place at the right time. And like today, everything goes on without a hitch. Thanks once again to IAP and Neelam. Mohan, being a busy person, has taken time. I still remember long back she had told Dr. Ranjan, I also would want to take part as an speaker or academician, not just as president-elect. And she has kept her word and made time for today's session. Thanks, one and all.
Thank you. Dr. Salman, if you're there, can you talk a few words before we sign off? Sorry, I think Dr. Salman also has signed off. Thank you all for your attendance. Until we meet next time, fourth Sunday of the next month. Thank you.
So much, Vanita. Thank you.
Thanks.
Bye, everybody.
Thank you,
Bye-bye.
Bye,
Ranjan.
doctor.
Thank you, Neelam. That was great.